It's a great pleasure to be speaking at the FE Digital Health Conclave 2.0. The FE has been in the lead as a thought leader on many different aspects of health. And during the pandemic, I remember having had several interactions while I was still at the WHO. So the topic we're trying to tackle today really is the future of digital health. And India is in a particularly good position because I think the investments in the digital infrastructure and backbone started many years ago. And the fact that many countries are still at a very early stage, whereas India is already well on its journey in the digital transformation, particularly having had a very strong impact on the financial and the banking sectors. So I think it's a good moment to look at how do we leverage the investments that have been made in terms of the hardware, the software, the connectivity, the linkages to the health issues that the country faces today, and particularly with the goal of universal health coverage that's been articulated under the Ayushman Bharat mission and program. Now, there are many different aspects of digital technologies, but I would just like to touch on a few because there are other experts probably who know much more about the technology. But I'm looking at it from the point of view of both a healthcare provider and perhaps also a healthcare user, and trying to see what are the lessons, or rather, what are the issues that one needs to think about when, as a policymaker, one is considering, how best to leverage this. So I think there are many examples during the pandemic, actually, that we could use as example pointers, case studies, perhaps. For example, the use of the COVID app. Now that provided a platform for not only digital certification of vaccination, but also a means to stay connected with, over 1 billion people who received the COVID vaccines through the government's vaccination program. Now, just thinking about applying something like this, say, to tuberculosis, or, for example, to chronic diseases like hypertension and diabetes, where patients need to stay connected with their healthcare provider, and the healthcare provider needs to stay connected with the patient on a very long-term basis. And the fact that physical encounters could be minimized by the use of technologies like these apps, through which one can have a two-way communication. It's not enough to just have a one-way communication, but ultimately one would also be able to send prescriptions, as well as send images and do a number of other things. The other area I think that was used a lot during the pandemic in many countries, but also in India, was the telemedicine or telehealth program that was launched and that has actually taken off, and that again provides an opportunity for linking specialists who may not be available in rural areas with both patients directly, but also with healthcare providers in the more peripheral units. We could take this a step further and explore how to make the system even more efficient. I've had good experience with the ECHO platform, for example, which is a platform really for training and mentoring of healthcare providers, be they doctors or nurses or other cadres of people who can connect with experts and whose knowledge and whose abilities to treat a particular condition improve over a period of time through these interactions that are held on the digital platform. Today, I think one of the most important issues is our health workforce. How do we actually create a workforce that is not only initially well-trained and well-equipped to do the job, but is constantly mentored as well as monitored and where the quality of the services they deliver actually gets much more priority. So, for example, we have now the health and family wellness centers, which may or may not have doctors. They may have an Ayush doctor, or it may be manned by a nurse or two nurses. They are expected to deliver primary health care, the basic primary health care, to the population of, say, 5,000 or so living around that health and wellness center. Now, over a period of time, through this type of training and mentoring approach, using a digital platform like the ECHO platform or any other platform that allows an expert or a specialist sitting in one place to provide this mentoring to a number of similar healthcare providers who are connected. For example, NIMHANS is one of the centers. It's one of the hubs for the ECHO program. Now, NIMHANS is able to connect with doctors across India to discuss the management of different mental health problems, whether it's alcohol withdrawal, whether it's schizophrenia, etc. Whereas the doctors sitting in the primary healthcare center, who may not be experts in mental health, over a period of time, learn how to independently manage these conditions because they have been tutored and mentored and supported by the experts in NIMHANS. Similarly, the program's been running in India for MDR TB, multi-drug resistant TB management. It's run out of the LRS Institute in Delhi, and it's been training and mentoring doctors across India. So there are many examples, and I understand that many state governments now have MOUs with the ECHO India platform to do this. So this is one application of a digital platform and a tool which can be used for capacity building and also for monitoring the quality of care provided. A second application, which it still needs to be actually tested and tried in India, is the issue of virtual shared care. So what do we mean by virtual shared care? First, virtual care, I think we all understand, the telemedicine or telehealth services. It's usually a one-on-one between a doctor and a patient, or a healthcare provider and a patient. Here we're talking about shared care, which means that there's a group of individuals with a similar healthcare condition. It could be diabetes, it could be hypertension, it could be glaucoma, it could be a neurological illness, maybe like a post-stroke rehabilitation. Now, we know that these are sometimes needing expert opinion, and these experts and specialists may not be available in the community care centers or even sometimes in the district hospitals. And anyway, then patients have to travel back and forth to get this expert advice. Instead, patients could collect at either the primary health center or the health and wellness center in a group. So this is where the concept of shared care, let's say there are 10 patients with hypertension in a particular health and wellness center that want to collect on one day, and then through tele, the link is established with the expert, internal medicine specialist or cardiologist, who could be at a medical college hospital or at the district hospital. And then there is a session, say for 30 minutes, where there is a back and forth between this expert and the patients, discussing the management and the control of hypertension, the do's and don'ts, the diet, the exercise. And because it's a question and answer type of session, while one patient is maybe asking the question, the others are also listening and learning. This was tried as a randomized trial in the Arvind Eye Hospital for glaucoma. Of course, it was not done virtually, it was done in physical groups, but the outcomes were that the group consultation was not only as good, but better in terms of patients' understanding and acceptance and health outcomes than individual one-on-one visits with the doctor. So this concept is a relatively new concept of virtual shared care. I think that given the shortage of specialists in rural areas and the need for expert advice, such a model could be tested, tried, and then scaled up through the eSanjeevani platform that already exists. Now, another important area for us to think about, in fact, very critical, is really on the data, because this digital platforms are now going to allow, obviously, the collection of large amounts of health data, including electronic health records. These are all going to be placed in digital locker. The patient is going to have access. I think the vision for this is very clear, and it's very inspirational. Now, the issue is how much of this data should be made available and accessible to a third party, let's say a government institution, for analysis and for policy inputs. We know that that healthcare systems can only improve based on feedback loops, and the feedback loops need to be based on patient experience and outcomes. So both qualitative and quantitative data are important. Now, considering that vast amounts of data are going to be collected, there needs to be now, I think, a dialogue with civil society, with the community, with really all of participants or citizens who are going to be actually the beneficiaries of electronic health records, as to how much of my data am I willing to share, and what are the boundaries that I would like to see, so that I don't feel that my privacy is being compromised, confidentiality is being compromised, and that I should not suffer any adverse consequences because I agreed to share my data. Now, there are countries, Estonia in particular, but there are others as well, Finland, where citizens have actually agreed that the government can use their health data for analysis and for improving their own programming, provided that it's not used commercially, that it's not sort of sold to insurance companies and so on. So I think there is a huge opportunity here. It's, of course, a challenge in terms of the variety of views that one will get, but it's important to have that discussion and debate as to where is the data needs to be absolutely protected, confidential, where privacy should not be breached, and what are the kinds of data that would be okay, for the government to use as for analytics and for example, the TB control program runs Nikshay, which is a very large electronic database. Perhaps it's one of the forerunners, of other such digital data collection platforms. And we can learn from that experience. How has the Nikshay data enabled the TB control program to do its job better, to reach, maybe people in unreached areas, or to compare the performance, between districts or states, and for many different, to look at gender, to look at other determinants of health. This brings me to artificial intelligence, which obviously is something that attracts a lot of attention. Today, it has many, many applications for health, ranging all the way from diagnostics, which can be applied, the algorithms can be applied to X-rays, to pathology slides, to symptom complexes. They can be used in decision support tools. All of these, of course, need careful validation when these algorithms are developed. They need to be tested and validated on data sets that represent the population where they're going to be used. This is very important so that the biases can be detected or are not going to impact the performance. And they can be very useful additional tools, especially again where, let's say, pathologists or radiologists are not available and one needs to make a diagnosis quickly. There are many medical devices now that are coming up that are using artificial intelligence algorithms for diagnostics, and there needs to be a regulation around these. The FDA has a regulatory framework for artificial intelligence-based medical devices and diagnostics, and I think this is going to evolve over a period of time. The WHO last year came up with a guidance document and a framework, both for the ethics, looking at the ethics and the regulation of artificial intelligence in health. And this is a very comprehensive document that speaks to policymakers, to developers of these AI-based tools, but also to healthcare providers, hospitals, or healthcare facilities that might want to use it, because there'll be legal issues that come up as well in terms of liability and so on. So there are risks and benefits, of course, of using any new technology, and similarly for artificial intelligence. So one needs to weigh in which situation is it better, or are there more benefits compared to risks of using an AI-based tool compared to, say, using the ordinary human. And this can only come when good data is collected, when good research is done, and we need a lot more research around the use of digital health, around the use of artificial intelligence in health, especially implementation research that can then inform our policies. So there's a plea really for more institutions to undertake research in these areas of cutting edge new technologies. So artificial intelligence is going to play a bigger role. We have to be very careful and cautious in terms of the ethics of it. But this is why the WHO guidance document will be important. And it's important for the government to lay down the rules and regulations. The private sector obviously plays a very important and key role here in developing these solutions. And it's much easier for the private sector to work when there is a framework that's already been articulated by the government and a regulatory pathway through which they have to pass. Now, the thing with AI-based machine learning algorithms, of course, is that they tend to get better the more they're used and the more data that they see. And therefore, the regulatory pathways also are slightly different from those for, say, a drug or a vaccine, where you go through it once, the clinical trials, and then you get it approved. And then you may do a post-marketing surveillance for safety, but really you don't need to go back to the drawing board. Whereas in this case, the machine learning algorithms, we may have to reset every couple of years if there is enough improvement or change in the performance of that particular algorithm. The last point I'd like to make is around attention to equity. And I think, again, this is very important because on the one hand, digital technologies can help us to reach the unreached. They can help us to go to people who traditionally may have had problems with accessing traditional healthcare facilities. But on the other hand, it can also serve as to become as exclusionary as traditional health services, and may end up excluding the same people who, had poor access anyway, who are likely to be the poorest of the poor, the most vulnerable, the most hard to reach, the most marginalized, perhaps those in the most remote areas where there may still be problems of connectivity. Last year during the pandemic, I traveled to some tribal hamlets in the Nilgiris where I found that children had to walk 17 kilometers in order to access connectivity, and therefore they had absolutely no schooling for the 2 years during the pandemic when other children were able to access online classes. So these sorts of areas may be few and far between, but they still do exist in India. And therefore we must see that whatever solution we're rolling out doesn't end up excluding certain groups of people. So we have to keep equity at the heart of everything we do. This is particularly true for health, where universal health coverage and really the philosophy behind leave no one behind needs to be put into practice and not just be a principle. And again, this can only come from being very sensitive to this issue and ensuring that at the distal levels of providing care, that we take feedback from the communities, from people who, and from the frontline health workers who know the ground realities and understand whether certain solutions are helping or hindering the delivery of healthcare services. I think I would like to suggest that in terms of our digital health mission, but also our national health mission, we need an external feedback loop. We need the end users to be able to provide their inputs into what's going well and what may not be going so well. And this can only serve to further strengthen and help the programs at the state and the central level to do an even better job. So those are just some of the thoughts I had shared. I know that digital health is one of the priorities that has been put forward for the G20 by India. It's been a priority also for other countries, and certainly the pandemic brought it, to a very high level of attention. One of the programs that I was working on at the WHO was the whole development of the SMART guidelines or the living guidelines approach, which again allowed us to use the power of artificial intelligence and digital tools to update our guidelines. Of course, we cannot do away with humans. I think we have to remember that it's only a combination of artificial and natural intelligence that can help us to do our jobs better, but certainly it can help speed up the process right from drug discovery all the way to updating clinical treatment guidelines. These tools are powerful ways of helping us, healthcare providers, actually deliver better care for people. Thank you very much.